Welcome to the MS&Me Radio Network. The broadcast shows are for informational and entertainment purposes only. They are not designed to provide listeners with specific personal, medical, or counseling advice. Individuals with a medical issue should always consult their healthcare provider. MS&Me is not responsible for content of individual shows. The views expressed by show hosts or their guests are their own. Enjoy the show. Welcome to MS&Me Interviews. I am your host, Erica Lyons Richardson. This is part 2 of our annual ACTRIMS review, where we take a look at highlights from research presented at the ACTRIMS Forum. This is from a patient's point of view. The 4th Annual America's Committee for Treatment and Research in Multiple Sclerosis, or ACTRIMS, Forum 2019 was held February 28th through March the 2nd in Dallas, Texas. Themed Precision Medicine Approaches for MS, Scientific Principles to Clinical Application. This CME accredited meeting stood apart from many traditional medical meetings by offering a singular track of scientific and clinical presentations in an interactive environment, as well as numerous networking opportunities. Highlights of the forum include the Kenneth P. Johnson Memorial Lecture and the National Multiple Sclerosis Society's Barancik Award presentation and talk. In addition to 2 poster sessions showcased approximately 200 posters. ACTRIMS is committed to fostering the careers of young investigators with an interest in multiple sclerosis. The first session of the forum was composed of a platform presentations of young investigators who were selected based on a review of the submitted abstracts. In addition, junior faculty fellows and students who submitted abstracts were eligible for an education grant to support their attendance. Neurologists in training learned about career paths in clinical and investigative neuroimmunology through the pre-conference event, Neurology Resident Summit in Multiple Sclerosis. ACTRIMS Forum 2019 provided an excellent opportunity to interact with scientists and clinicians at the cutting edge of MS research. The inaugural ACTRIMS Forum, held in New Orleans back in February of 2016, was a great success with over 600 participants, well surpassing the original projected attendance of 250. Year after year, they just have record-breaking attendance with nearly 1,000 in attendance back in 2018. The MS&Me media team had an amazing time serving as press in 2018 in San Diego. ACTRIMS continues to further the mission of providing leadership in the field of multiple sclerosis and other debilitating diseases. Now on to this week's topics. Retinal layer thinning in MS advances with the disease progression. People with progressive multiple sclerosis show accelerated atrophy in the inner and outer nuclear layers of the retina compared to those without the disease. This offers an important new pieces of the puzzle in understanding the changes that occur when MS advances, researchers have said. We have found that We have found that progressive MS is associated with accelerated inner and outer retinal layer atrophy, independent of age and clinical characteristics. That was according to the opinion of Dr. Elias Sotrokos, a clinical and research fellow with Johns Hopkins University School of Medicine in Baltimore, Maryland. Now, the findings were presented in the IMS Visual Symposium at the America's Committee for Treatment and Research, ACTRIMS Conference 2019. The thinning of the peripapillary retinal nerve fiber layer, called PRNFL, and the ganglion cell plus the inner plexiform layer observed on an optical coherence tomography, that OCT test, are known to be accelerated in MS, even in the absence of optic neuritis, which, of course, you know is common in MS. Now, the changes in thickness of the inner and outer nuclear layer of the retina have also been identified in MS. However, the changes that can be difficult to interpret, while atrophy is identified in as many as 40% of the postmortem eyes. Now, the increased thickness of the inner nuclear layer has conversely been associated with inflammatory disease activity in MS. And as you know, MS is not only an inflammatory disease, it is a demyelinating disease. It is both. The differences are likely the result of the retinal pathology at various stages of the MS disease course. However, with most OCT studies comparing retinal measures between MS subtypes involving small numbers and progressive MSIs, and focus largely on that PR-NFL measure, a better understanding is needed. And now, to take a closer look at the longitudinal changes in retinal thickness in relation to the age and MS disease progression, the doctor and his colleagues evaluated OCT data on 349 patients with MS. Now, this included 174 with relapsing remitting MS and 186 with progressive MS. And he compared them with 66 healthy controls. Similarly, faster rates of atrophy of the inner and outer nuclear layers were seen with increased age among those with and without MS. Now, the doctor said given that the accelerated inner and outer nuclear layer atrophy was observed, only the progressive MS patients compared to healthy controls' inner and outer nuclear layer atrophy appears to be specific to progressive MS and is likely representative of the insidious neurodegenerative MS process which occurs at this stage of the disease. Now, the findings of the accelerated PR-NFL and the GCIP atrophy in progressive versus the relapsing remitting patients are also novel, he said. All right. So the doctor stated that all MS disease subtypes had accelerated atrophy of these layers compared to the healthy controls, suggesting that this is a feature of, that progressive and relapsing remitting MS have in common, albeit faster in the progressive patients. All right, so that's how he explained those results. In addition to the need to reproduce the findings in larger multi-center cohorts, it's important that our next step in the research include the need to look at how the changes relate to disability outcomes and the effect that the disease-modifying therapies may have on the retinal changes. So it could be also there might be, some treatment-related changes in these tests. Now, in discussing the research in a separate talk at the meeting, Dr. Shiv Seda, and I probably just totally butchered that name, senior investigator on the study and associate professor of neurology at Johns Hopkins University School of Medicine, Baltimore, Maryland, underscored that damage to the optic nerve eventually occurs in nearly all MS patients, believed to stem from optic nerve inflammation. Now, at postmortem, up to 99% of MS patients have demyelinization of the optic nerve. What that implies is the optic neuropathy is virtually ubiquitous phenomenon in MS disease process. The prevailing hypothesis is that there is demyelination or axonal transection related to acute inflammation that occurs in the optic nerve, with a retrograde degeneration of the axons that result in a thinning of the inner and the ganglion cells. Now, while previous studies have suggested that inner nuclear layer thickness at baseline in MS is predictive of future clinical as well as radiological disease activity and progression, the new findings offer important insights on that relationship. Now, Dr. Seda had stressed that at ACTRIMS. Although the study has a decent-sized cohort, he didn't know if he would pin his hat on saying that this is in terms of a novel retinal biomarker that may have utility specific to progressive MS. But he's very excited about it, and the goal will be to take a much deeper look at it. Now, Dr. Orhan Kantarshi, an associate professor of neurology at the Mayo Clinic in Rochester, Minnesota, agreed that the study offered compelling data on the role of the inner and the outer nuclear layer. But he said that, if we're going to prevent things from happening clinically, we want to try to stop them subclinically before we get to the clinical problem. So that, in that sense, is an extremely important piece of the work. Similarly to atrophy that we may see in spinal cord or thalamus or brain, these are biomarkers of the ongoing insidious process that's happening in the background of MS progression. Now, Dr. Kantarshi, who was not associated with that current research, made those statements. Now, by the time MS progresses, it's already a little late. In the future, if we have the markers to tell us what's happening long before we see these things clinically, then hopefully we can develop treatment strategies to prevent them. Our next topic is use of ACTRIMS at Cleveland Clinic backs the phase 3 trial data, real-world experience with the ocrelizumab. Now, efficacy and safety of ocrelizumab were demonstrated in 3 phase 3 randomized controlled trials. This follow-up study evaluates generalizability to, like a real-world setting use of ocrelizumab. The objectives were to evaluate the effectiveness and safety and tolerability of ocrelizumab in clinical practice. The methods of this study were that this was a prospective longitudinal cohort study. Patients were identified by a chart review and data was abstracted from the electronic medical record. Patients had to be 18 to 75 years old, start ocrelizumab after a regulatory approval, be followed clinically for at least 6 months prior to the start of ocrelizumab, and have confirmed diagnosis of MS and have relapsing, remitting, or primary progressive disease course. Now, demographic data, disease duration, prior disease modifying therapies, their baseline, monitoring MRI screenings, and monitoring laboratory assessments, infusion-related reactions, on-treatment side effects, and quantitative neuroperformance, and then the patient-reported outcomes were all collected for the study. Okay, overall results. The overall report results say that as of 5/14/18, 748 patients had been treated with ocrelizumab at that center. The center reported the results of the first 272 patients with 6 months follow-up, and 208 had RRMS and 64 had PPMS. The demographics were similar to the clinical trial population. Median age being 47, 60% women, 84.8% white, 11.6% black. Compared to the clinical trials, the population had longer disease duration, 13 years versus 7. And fewer patients had enhancing lesions at baseline. Then at 6 months, 126% 126 patients had CD19 B cell count greater than 0 cells, 14 with a normal range, 10 were treated for a clinical relapse. That was 3.7% of their patients had to be treated for relapse. And 6 or 2.2% corroborated by exam or MRI. 8 had, or 2.9%, had a serious adverse event. And 57 of the patients, or 21%, had an infection, mostly common UTIs or URIs. 49 had an IRR. So the conclusion of the overall study. Ocrelizumab is a highly effective treatment for MS. Rates of adverse events are lower than reported in clinical trials, possibly due to the difference in reporting. Compared to clinical trials, the patients at the center had different disease characteristics with longer disease durations and fewer enhancing lesions at baseline. The effectiveness and safety of Ocrevus or Ocrevus, as some people say, in relapsing MS and PPMS patients were demonstrated in 3 phase 3 trials. 2 with relapsing remitting patients, the OPERA-1 and the OPERA-2 studies. Now, the other 2 studies and 1 in PPMS patients named Oratorio, based on the data from all these trials, the FDA approved Ocrevus on March 28, 2017. Now, however, the research does not stop there. With Ocrevus's approval, it is necessary to monitor and scrutinize its effectiveness, safety, and tolerability as it begins to be used in the clinical practices around the United States and the world. People in clinical trials are highly selected for and may not represent the full spectrum of the disease that you see in clinic. So, they want to make sure that what you see in the clinical aspect replicates the findings that you had back in the clinical trials. Thus, the Cleveland Clinic researchers decided to assess how Ocrevus was performing at their center compared to the results in the previous phase 3 trials. They ran the prospective longitudinal study, the examination of the group subjects by assessing the treatment outcomes over the period of time for tolerability, the safety, of course, the effectiveness. Now, the patients are treated at the Cleveland Clinic, all right? So it's just at this one center that this follow-up study was ran. Now, the team analyzed the 748 patients, and they were 18 to 75, as we said before, and they had actual better outcomes than in the trial studies. And that's not unusual. You know, we have seen several follow-up studies, one presented at ACTRIMS last year, and the warnings that were put on the label for PML. We have not seen any cases of PML actually related to Ocrevus. So now, you know, that's why Ocrevus is being prescribed widely to patients that are JCV positive. JC virus, that's John Cunningham virus positive. And so no PML cases. The risk for cancer was a concern on the label. And the reason that these label warnings are put on there, any condition that is, you know, experienced during these trials by the patients has to be put as a warning for a possible side effect for the medication, even if it's completely unrelated to the medication. And that's what's been the outcome for PML. It actually was related to their patient's previous treatment, not to Ocrevus. So Ocrevus doesn't actually have that risk, as demonstrated in the follow-up anyway. And then the cancer risk. That cancer risk actually in follow-up studies, the numbers ended up a lower risk than average population that didn't even have MS. So, you know, and during the trial, the numbers actually were almost completely equal to general population for people who didn't have MS. And now the numbers are turning out to be even lower. The risk is even lower. So, it's really good to follow these follow-up studies for any medication that you're considering or you're already on. It's great to really follow all these follow-up studies. And sometimes we find out there's no risk. The numbers are even better than in the trials. So what, looked like a groundbreaking treatment turns out to be even better than we expected. So we're definitely going to keep follow up on this one. Now on to our next topic. Leukocyte telomere length shortening is predictive of disability progression in MS. Okay, so for this study, as the protective molecular caps of our genetic information called telomeres become shorter in certain immune cells, the extent of the MS disability progression increases. Regardless of age, researchers at the University of California, San Diego has reported in this new study. The findings were presented at ACTRIMS 2019. The presentation given by Kristen Cresco from UCSF was titled Leukocyte Telomere Length is associated with disability progression in multiple sclerosis independent of chronological age. The study suggested that preserving telomere length can be a therapeutic or preventive strategy for MS. Factors contributing to MS disease progression are not fully understood, although older chronological age is a factor known to be associated, of course, with faster time for a patient to reach certain disability milestones. This suggestion that age-related mechanism in cells and damaging, the damage to those that protect the cells from aging may contribute to neurodegeneration underlying the MS progression. A process associated with aging is the shortening of the telomeres that protect the ends of chromosomes, long strings of DNA that contain genetic information. Telomeres shorten every time that the cells grow and divide. It's a naturally occurring biological aging process. However, telomere shortening can be sped up by DNA damaging factors such as UV rays. Although several diseases have been linked to excessive telomere shortening, such as heart disease, dementia, autoimmune diseases, and also primary progressive MS. Interestingly, the telomere length in leukocytes, immune cells involved in the counteracting, the foreign substances and the disease, has been linked with MS disease progression. However, how chronological aging, biological aging, as measured by the leukocyte telomere length, and MS progression are associated is not known. Researchers at UCSF dove into this question. They examined the possible links between leukocyte telomere length, chronological age, and disease duration with brain volume and clinical disability in MS patients. To do so, researchers took advantage of UCSF's EPIC cohort study, an intensive observational study of more than 500 MS patients who have been carefully followed since 2004 to gain a greater understanding of MS susceptibility and long-term progression. In total, data from 356 women and 160 men were analyzed. At the start of the study, researchers found that shorter leukocyte telomere lengths were strongly associated with greater chronological age and longer disease duration. In addition, they saw that brain volume decreased with a shortening of telomere length independently of chronological age, meaning that patients whose telomeres were shorter had more advanced disease regardless of how old they were. When patients were followed over time, results showed that those with shorter leukocyte telomere lengths at the start of the trial had increased EDSS scores and lower brain volumes over time indicating accelerated disease progression. The team also analyzed a subset of 23 patients who developed secondary progressive MS during the study, and these patients were matched on age, sex, disease duration, and with the participants who remained in the relapsing MS group. Now, results showed that in these 23 matched pairs, a change in leukocyte telomere length was predictive of change in disability EDSS score over 10 years. As the leukocyte telomere length decreased, EDSS scores, the disability scores, increased. Shorter telomere length was associated with disability in both cross-sectional and longitudinal analysis after adjustment for chronological age, suggesting that biological age may contribute to neurological injury in MS. Now, thus, targeting age-related process may be a potential therapeutic strategy in future studies. So that is a very interesting study to come out of ACTRIMS 2019. We're going to leave the next topic for next time for our part 3 of our ACTRIMS 2019 review. But we're going to go ahead and wrap it up here. Now, don't forget to tune in next week for part 3. Thank you all for joining me again for this week's part 2 review of ACTRIMS 2019. For more information, you can go to msandmemedia.com. That's msandmemedia.com. Don't forget to visit the MS&Me forums and pages and other resources on Facebook, Instagram, and Twitter. Thank you so much, and please join me again next week, same time, Sunday, 3 p.m. Eastern Standard Time, for part 3 in our review of the exciting information that was shared at ACTRIMS 2019. Have a great week, everyone.